Good afternoon, everyone. Thank you all for joining the TxRx Echo brought to you by the Center for Substance Use Training and Telementoring, also known as CSTAT, by Be Well Texas in collaboration with the UT Health San Antonio Echo program. My name is Angela Cruz, and I will be the facilitator for today's session. A few housekeeping items before we begin. Please do introduce yourself in the chat by entering your full name, affiliation, and email. We love to see where everyone is joining in from. Please do remember to stay muted unless you are speaking. We encourage using the chat and/or raise your hand feature to pose questions and share perspectives as well as resources throughout the session today. We'd love to see everyone join in by camera. We like to see everyone's smiling faces. This does increase connection and engagement. However, we do understand that certain schedules and clinic settings doesn't allow for that, so that's perfectly fine to keep your cameras off. But we would like to see you all. If you're having any connection issues, please privately chat Karen, our wonderful Echo IT, for further assistance. As a note, these sessions are being recorded and they will be shared on our website for future reference. Uh, Therefore, to ensure privacy, no personal health information will be allowed throughout the session today. This includes items such as names, addresses, and birth dates. And additionally, the slide presentation from today's session will be uploaded and shared on the iEcho platform for you all to reference later. And it will also be shared as an attachment in our post-session communication email. So be on the lookout for that if you'd like those slides. At the end of the session, the ECHO team will be sending out a post-session survey link. This survey link is really, really important. We kindly ask you all to complete it because it gives us really great insight on how to refine these sessions and address topics that you all want to learn about. We will go ahead and move on to team introductions. I'll begin with our hub team, Dr. Walker.
Hi, good afternoon, everybody, and welcome. Excited for today's presentation. I'm Crystal Walker, physician assistant and a doctorate of medical sciences. I'm currently the director of substance use disorders clinical and medical services for MHMR of Tarrant County in Fort Worth, Texas. Happy to be here.
Thanks. Thanks so much, Dr. Walker. Dr. Short.
Good afternoon, everyone. I'm Daryl Shorter. I'm an addiction psychiatrist here in practice in Houston, Texas, and an associate professor of psychiatry at the Baylor College of Medicine Department of Psychiatry. Thanks.
Dr. Shorter. Dr.
Hey gang, I'm John Embers. I'm an internal medicine doc and addiction specialist here in Austin, where I'm faculty at UT and the director of substance use disorder integration at the hospital health district here. And excited about the talk and case today, which I think will offer a really rich integrated discussion.
Thanks so much, Dr. Weems. Dr. Cole.
Hi, Alicia. Dr. Kowalczyk with Baylor College of Medicine, Department of Family and Community Medicine, boarded in Family and Addiction Medicine, and I serve as medical director of Santa Maria Hospital as well. Thank you.
Thanks, Dr. Kowalczyk. And our case presenter for today, Dr. Carlos Tostado.
Hi, everybody. My name is Dr. Carlos Tostado. I'm an internal medicine physician at UTMB Galveston and addiction medicine specialist here at UTMB Galveston. Thank you for having me.
Thank you so much, Dr. Dostal. And our didactic presenter for today, Dr. Zagorski.
Hi, everyone. Not a doctor yet, but I'm Claire Zagorski. It's totally fine. I hopefully will be in just a few months. Everything keeps going the way it's supposed to. I'm Claire Zagorski. I'm a PhD candidate in the College of Pharmacy at the University of Texas at Austin. And I'm thrilled to be here today.
Wonderful. Wonderful. Thank you so much, Claire. Future Dr. Zagorski. Thank you all. Thank you all for your introductions. Please continue sharing your information in the chat. And before we move on to didactics, ECHO is an all teach, all learn environment. We encourage all of you to participate in today's conversation and raise questions. And let us always make every effort to continue having this space that is safe and respectful for all of us to learn together. So with that, we'll get started with didactics. Claire, you may take it away. Thank you.
All right, thank you so much. Okay. Does this look good to everybody?
Yes.
All right.
Almost. We
That's
just
right.
need to see it in presenter mode. Yeah. There we go.
Perfect. All right, thank you, team. All right, okay. So hi, everyone. I'm Claire. I'm excited to talk about this today with Kratom and 7-OH. A really quick primer, there is a lot to say about these substances, and there's also a lot that isn't really well known about these substances. So I apologize if my 20-minute talk, 'cause I'm going to try to keep it right on time, doesn't cover certain things. More than welcome to email me if you have a particular question or thought that you can't get addressed today. And again, to echo Angela, my email and my slides are going to be in the email that you receive after this, so don't hesitate to reach back out. I just want to disclose I do not have any kind of financial relationships to disclose that are relevant here. And again, views expressed, not necessarily anyone's except mine. Okay, so we're going to talk a bit about pharmacology and actions of the drugs that we're talking about today, the mitragynines. We're going to hit some particularly salient clinical points, and then also kind of understand how these mitragynines are folded into people's lives at this point, and kind of what to understand when you have someone in front of you. So one of the bigger things that I see people getting really confused about is what on earth is going on when we talk about kratom. What is 7-OH? Like, what is this? So an analogy that I like to make is that when we talk about this in kind of big, broad terms, it's almost like how we talk about cannabis, in the sense that cannabis, quote unquote, is actually this entire plant that actually has a bunch of things in it. It's got dozens of compounds in it. There's the big daddy THC that we know is psychoactive. This is really well understood. You can extract THC from cannabis, but that's not the only thing in there, right? So if you are smoking whole leaf, you're getting multiple different molecules. Some have more effects than others, and there's a lot that we still don't know about all the things in cannabis. That's kind of a similar context to what we're looking at here. When we talk about kratom, we're talking about this entire plant and the leaves off of it. So the leaves are what is consumed. And they're these little brushy looking trees here. This is a photo from the University of Florida. They have a lot of kratom research, including actual kratom trees, and they're interested in kratom agriculture, which is interesting. So that the name kratom refers to any product really from Mitragynine speciosa, which is the name of this plant here. But again, it being a naturally occurring plant, there's a lot of things in it. There's a lot of substances in it. This is important to remember because when we talk about the pharmacology of a certain molecule, what we've learned by getting that information is we've given the specific extracted molecule to, usually we're starting with a rodent, and we are only seeing the effects of that specific molecule because that's how you do that kind of basic preclinical science. But if we are talking about a whole leaf compound or a whole leaf preparation rather that is consumed by our clients and patients, there's more to the story. There's more going on there. So that's just an important thing to remember. When we talk about pharmacology studies, we're usually seeing the results of a very specific purified compound given to a test animal. And that's just a different context than what we're seeing usually. Way more research is needed on these. We're behind on preclinical research in drugs like these for, the obvious reasons. We're trying to get caught up at this point, and there's some really interesting work ongoing. For considering the pharmacology, there's a lot. There are truly dozens of things. And kratom, I'm going to focus on these two because these are the two that we're seeing the most, seem to have the most clinical relevance, and we actually know something useful about them. So mitragynine and 7-OH mitragynine. 7-OH mitragynine can also be called 7-hydroxymitragynine. I apologize in advance to anyone who took organic chemistry and was traumatized by it. The 7-OH just refers to a modification of mitragynine. So if you have the molecule mitragynine in front of you, the 7 refers to the 7th carbon, which is a numbering system I won't explain right now. The 7th carbon has an oxygen and a hydrogen tacked onto it. So that's the naming system there. So it's not a totally different thing. It is 7-OH is a semi-synthetic. So it starts with mitragynine and is modified in the lab to add the OH group on that 7th carbon. So just to clear that up. So with both of these, 7-OH mitragynine is quite a bit stronger than mitragynine, and I'm going to get more specific than the word stronger in here in just a minute. But we both know that generally speaking, they are partial agonists of mu opioid receptors, and that's the kind of the big daddy opioid receptor, right? That's implicated both in pain and euphoria. They are also partial antagonists, so they partially block kappa and sigma opioid receptors. And that is, it's not entirely clear the relevance there, but the fact that they have some partial antagonism seems to probably be what's going on with the fact that we don't really see the kind of scary overdose effects that we do see with traditional opioids like fentanyl, and I'm going to get into this later. We really aren't seeing the kind of, bradypnea and apnea that we see with traditional opioid overdoses. And that probably has to do with the fact that there's at least partial antagonism of those opioid receptors. So they both have pain relieving effects, and they both are described as being very euphoric, especially 7-OH mitragynine. And this is also a little bit dose dependent. Something that's kind of famous with Kratom is that at lower doses, it has more of an energizing and uplifting effect, kind of like a lesser stimulant maybe. And then at higher doses, we see more of this classic opioid effect where it's more sedating, makes you feel, or it's better with nociception, like pain relief at that point. So it is kind of an interesting kind of bimodal effect here with dose. One thing that's also interesting, and I'm not going to get into the specifics because it gets real animal research real quick, and I don't want to take too much time on that. It doesn't seem that either of these activate the major pathway implicated in apnea. So like that loss of breathing, they do not activate beta arrestin, they don't recruit it. And that's the kind of the big thing that we think is triggering that fatal apnea that we see with people that overdose on something like fentanyl. So that's interesting. And there's a lot that we're learning from watching what Kratom does to help us understand the action of the brainstem in overdose. There are important differences here between the two. I'm sure some of y'all have heard about this, at least anecdotally. So 7-OH with that modification, so it's about 10 times as potent as the mitragynine itself. 10 times as potent as the unmodified mitragynine. And for those of you that haven't thought about this recently, potency means that there's just less of a dose is needed to get some determined effect. So greater bang for buck, think of it that way. It also has greater efficacy than mitragynine, and efficacy describes the total potential effect of a drug. So something with greater efficacy, it means it has higher potential effects, a higher ceiling. So it can get further regardless of the dose that you would give, if that makes sense. Probably for both of those reasons, it also has greater dependence potential, and it has greater potential for fatal apnea. I spent some time looking through like the coroner's reports on these, or the write-ups of the coroner's reports rather, and it's a little unclear that 7-OH on its own caused any of the implicated fatal overdoses. And I put a big asterisk on that because I don't want to say that this can't cause it. I think it's a lot less likely to cause a fatal overdose for the pharmacology reasons that I laid out. Most of the examples that I was able to find also included pretty high blood alcohol contents in the decedents. So we aren't super sure. I'm going to get into that more here in a minute, but I do want to really emphasize that even the 7-OH, which is considered the more kind of concerning clinically, it does not seem to be approaching the kind of risk profile that we see for something like illicit fentanyl. In terms of real world use, this is a very poorly regulated market. It keeps shifting under our feet, and I'm talking week to week. I'm seeing differences and changes in the market, especially across the country. And there being no good federal oversight system means that we're seeing all kinds of odd stuff. So I want to talk about the clinical implications of this and like the big take homes. So Kratom in the US in 2026 is usually consumed as a powder. That's the most common method. It's not the only one. Um, so this photo over here of the powders that I've got and these capsules, that was taken at a place in Houston. So this is a context that we're seeing in Texas. Uh, these products are also available as liquids. Feel Free here is a particular brand that's gotten a lot of headlines, and these are sold as like little 5-hour energy sized shots. And they're marketed without using the word kratom or mitragynine up front. You have to go to the website to find that it contains that. Um, and the way that it's marketed feels very like kind of all natural wellness. And it's concerning marketing to me, and I'll get to that more here in a moment. So you can also consume this as a tea, which is one of the more common ways it's consumed by the indigenous populations that claim this tree. You can also chew whole leaf. You can smoke it technically, but that seems quite uncommon. I found one person on Reddit talking about that. Something for everyone. There's a lid for every pot. Um, and yeah, so I have worries about this, and this is something that I want to kind of pass on to y'all to pass on to clients and patients, is that I'm seeing a lot of marketing terms that are unfortunate, things like natural plant-based energy, things that really make people imagine this as being very benign. And marketers are good at what they do. They use psychology to get to you to separate you from your money. So this kind of language can be quite potent. Um, Particularly for the folks that are maybe in recovery and are trying to just really focus on something sustainable and more benign to help them with energy, for example. We need to be careful with that. Natural does not mean safe necessarily. So again, this is something to be really careful about because the language being used sounds very safe. And if you don't know that what you are consuming has kratom in it, that can potentially threaten recovery. So I want to make sure that y'all understand that the context that we have, there are some places where it is loud and proud on the package. This is kratom, this is 7-OH. And there are other contexts where they take pains to avoid putting that on the bottle or the package. So one of the things I want to emphasize to the audience today is that I'm seeing very slippery marketing and package labeling. So I really want to emphasize that it's important to let the folks that we take care of know that that is the context. And so they need to be extra diligent if they're trying out a new supplement. Pardon me. Also, this is going to necessarily be a risk to teens, for example, who, our frontal lobe is not fully baked yet. We don't have fully developed critical thinking skills. And also sometimes they just simply have poor media literacy and marketing literacy. That's something that we all have to learn. And, I do want to point out that we have seen similar context to this before. So when I was kind of preparing this, I was like, this is so similar to pre-regulation tobacco. So we used to market tobacco in truly bold ways, including, having doctors endorse it, things like that. And we saw major plummeting of smoking rates after we made really big changes and restrictions in how tobacco could be marketed. So, careful, responsible marketing makes big differences in use. Okay, so one thing I want to point out, I feel like this tends to get lost in the discussion, is that kratom products are really promising. They've been used for a long time to help people treat their pain and also as a form of MOUD. And we probably all know people who have cited trying or just straight up using try to help them get away from the toxic supply of drugs on the street, particularly if there's some kind of barrier keeping them from things like buprenorphine and methadone. So, that's not to be discounted. And very, very, very long before we started using and seeing Kratom in the United States, this was a pretty commonly, and it still is, a pretty commonly used supplement for an energy boost and a little bit of pain relief by the indigenous people of Southeast Asia, where this plant grows naturally. So I want to emphasize that this isn't some kind of brand new scary thing. We're just seeing a different context for it that we need to really respond to. For example, if it's used, by the people in Asia that, grow it and have it as part of their life, it's usually chewing like a small amount of whole leaf, or they'll kind of drink a small amount of like a stew almost. But it's very much meant to be like a pick-me-up. It might help some with pain, but it's more like having an espresso. That's the most common use case for those kind of people. What we're seeing the big problems with in the States now is this high doses of especially potent 7-OH. So again, if you've been in this space for a while, you've certainly heard the maxim that the dose makes the poison. That is true here. So we're seeing the most problems with Kratom products overall with 7-OH, which is a semi-synthetic, very potent version of this drug, and larger doses of it. So to remember there. So in terms of kind of public health response, do try to remember, in as much as this makes sense in your care, that Kratom products, even 7-OH, are less risky choice for people who choose to use opioids extraclinically. And I'm not allowed to talk about the HR, but that's what it is. It is the less risky choice that can sometimes make sense for your discussions of care, and sometimes it doesn't, but be aware of that. Kratom products do respond to naloxone. They do not bond to the opioid receptor in any unusual way. So if we see, reduced rate of breathing, apnea, these potentially fatal complications of opioid use, naloxone is absolutely going to work. And in line with kind of other advice that we've been giving over the years, anytime we're using anything that can potentially slow down and depress breathing, we want to be very careful to avoid combining that with other things that can slow down and reduce breathing, like alcohol and benzos. Always excellent advice, right? And again, using substances like these with friends is always the safer option. Okay. More to say on this. So I mentioned that, this is an exciting, interesting medication. It is the subject of a lot of research right now. The fact that mitragynine blocks pain, reduces pain while avoiding apnea is really cool. This is really rare. And so there's a lot of research ongoing to try to figure out how to use this template that this medication has, this drug has, and try to figure out if we can make this into something that's really usable clinically for pain relief without the same kind of risk of traditional opioids that we have now, where we have to be really careful, particularly at higher doses, that we do not inadvertently harm our patients. So there's a lot of ongoing research right now. We need more, but there's ongoing research right now to try to figure out using these molecules for both pain and MOUD, particularly because they seem to inherently be safer. Again, very exciting. So we really need to support this work. We need to be excited about it. Having said that, I also completely endorse that the way that Kratom, particularly 7-OH, is being marketed and sold is concerning. I think it's irresponsible right now. We have to be really careful about who we're selling it to and how, and then also simply the products that are landing on the shelves. So any powder, so any kind of ground dried plant, very easy to contaminate. And this market has really poor regulation, as I mentioned. And one of the bigger kind of bugbears right now is that there's issues with heavy metal contamination in whole leaf kratom. And that is an inherent risk for anything, any plant that is grown in soil that's contaminated with heavy metals. So we're seeing issues with arsenic and cadmium and lead right now. And it is, of course, very hit and miss because it depends on the soil that the plant is grown in. To kind of make a point of comparison, in the United States, tobacco plants have regulations about the soil quality in which they are grown. So I think we should do that. And also the other things that we understand are important and good for consumer safety. So we want to limit marketing that appeals to kids, make sure that it is sold and marketed in a way that is responsible. And there's a lot of research that we have on that from tobacco, but it needs to be extended. Excuse me. And transparent labeling and product testing, I think, are really critical. Quick summary, and then I'm going to hush. This is a very rapidly moving and expanding market. It is impressive at how quickly it is moving. There is a lot that is unknown about these molecules. There's a lot of potential for kratom to be amazing. There are plenty of people probably on this call today that have great things to say about it. We need more research on it. We need regulation to make sure that it doesn't kind of get away from us and start causing harms. And I really want to pass on and emphasize to y'all, make sure that your clients and patients, if they are trying this, exploring it, that they understand that these risks are real. And one of the best things that they can do is really carefully read labels. If they aren't getting the information they need from a label, for example, it says specifically what's in it, they can check the website for the product. And if the brand doesn't have a website, they need to realize that that's not a great sign and that they are taking probably a significant risk in not knowing what they're consuming. Kratom products do have less potential for fatal overdose and illicit fentanyl. And this is an important thing to bear in mind. So again, we're going to keep watching for updates and encourage all of y'all to do that. Avoid panicking over this. It's very easy to do. And I completely agree that mystery drugs that can potentially hurt us are frightening. But we do need to avoid panic. It helps us think clearly and communicate clearly with the folks that we take care of. And I got some references for y'all to check out. And this is my email. And again, feel free to reach out anytime if you have questions about this. Thanks so much.
Amazing. Thank you so much, Claire, for that awesome presentation that fit in really nicely with the conversation we had at our last session and the case presentation on kratom use. Any question? Lots of praises, lots of clapping hands for you, and rightfully so. Any questions or comments from the audience for Claire?
Hello, my name is Kim Hibbets, and I work with an opioid treatment program in Lubbock, Texas. And I was just wondering, do you have any experience with people reporting extreme withdrawal symptoms from 7-OH products? We have actually had people come to our program seeking methadone or Suboxone treatment for their 7-OH addiction.
So yes to the latter. Like we absolutely see people that 7-OH is what gets them to present for treatment. And that's, I think, something that catches people on the side of the face. I didn't see that coming. They assume that this would be something that's very low threshold to the point where they're kind of escaping a medical context, perhaps. It's an interesting qualitative thing. In terms of like extreme withdrawal, that I don't know. I would love to hear from some of the folks that do MOUD. I'd be interested to hear like if Dr. Kowalczyk has seen this or Dr. Embers has seen this. I don't know. I don't have a great answer there. I would believe it just based on what I'm hearing and the fact that a lot of 7-OH is, again, we have adulteration risk all over the place.
I think it's a great question, and we're lucky to have a really great case with Dr. Dostal that really hits on this too. So I will hype that and then step back for more questions.
Dr. Dostal did mention in the chat, did you mention the half-life of 7-OH? I don't know if you
I
wanted
did
to add
not.
anything to that, Doctor. Okay.
Yeah, is that part of your case, Dr. Dostal?
No, it's not, but I think it's clinically relevant. And I've been looking to try to figure out exactly what it is. But in general, what I've found with patients presenting with either, 7-OH use disorder, or they're taking like, uh, upwards of 30, 40 grams of kratom daily and are having a kratom use disorder, is that they typically can't even really make it through the night without having to wake up in withdrawal, or so they're having to dose multiple times a day. And so without like being able to find a pharmacokinetic or pharmacodynamic study on 7 OHM, I'm just kind of speculating that the half-life of this stuff is probably pretty short, like on the order of like an hour or something like that.
That would track for me just based on the structure of the molecule. A general rule of thumb is anything that's more lipophilic that can penetrate the blood-brain barrier faster, which the 7-OH addition does, is going to also metabolize faster unless there's something else added to try to slow that. And it's not the case. So just in terms of like drug design, I would agree that makes a lot of sense. I don't think we have like a citable, referenceable half-life at this point in people, because as far as I know, all of the pharmacologic data that we're using to try to get a sense of kinetics is in rodents at this point. And anyone that's done any research like that knows that translating something like that into a human study is expensive and takes a lot of time. It's probably happening right now. I'm not positive, but yeah, we aren't unfortunately going to get that until we can at least test this with primates, and I don't think we're there yet.
Go ahead, Dr. Williams.
I'll just add that some work that was done out of Hopkins looking qualitatively at patients with who are presenting for kratom use disorders or older work before 7.0, because as Claire pointed out, things are changing so quickly. It indicated that it was the number of times administering during the day that was predictive of severity, both the severity of the kratom use disorder and the eventual dose of buprenorphine, regardless of the total daily dose. So it's just like very interesting. And again, these are small numbers, and we might be talking about a very different sort of drug as well. But I'm going to add that. And in my clinical experience too, Dr. Dostal is similar. If people are scooping this every couple of hours, I think we're talking about probably a shorter half-life. And then we're also talking about folks who we should be having discussions about MOUD to help offer them something that might stabilize them.
Thanks, Dr. Embers. Melissa, if you could unmute and elaborate on your question a bit. Does 7-OH test for opioids when given a UA?
Oh, like does 7-OH appear on UA? Is that the question? Because no, not at this point. I mean, the devil's in the details, right? So like if you just roll up to an emergency room, almost certainly not. I'm not aware of anyone that's baked that into their workflow in the clinical setting. You can always send urine off for GCMS or LCMS testing, just like the ship out tests that you can get as an addition. And they should, actually, I'm not sure now.
It's mitragynine. It can identify mitragynine, but not 7.0.
Yeah.
And I think 7.0 is very unstable. And
It
so
is. I was gonna say, I don't know that it would survive that.
it
Yeah.
would that I
Yeah.
saw
Okay.
some NIDA investigators talking about this. It is a major problem for research right now in 7.0, is that it cannot be identified accurately with LCMS, GCMS. However, these, like Claire pointed out, these are very unregulated products, and so there might be contamination of 7.0 with kratom, which would test positive potentially for mitragynine. The other thing I'll add, Dr. Dostal threw down these. I think these are, Carlos, do you want to say more about those? They have, is this an LCMS study or a immunoassay?
That's ARUP. That's the contract laboratory that we use. And again, like you guys just pointed out, they only have LCMS detection of mitragynine, not 7-OH.
There's some available immunoassays, so those are point of care tests or dip tests, urine tests. None of those are FDA or CLIA waivered. They were developed and they're marketed for forensic purposes, although they're sometimes used clinically, which means that with the clinician kind of gaze in mind, we don't know the test characteristics of those, and so making clinical decisions based off them is I would not recommend it.
Thank
I hope
you.
that helps.
That was my question. If testing would, detect, but good to know that we're still working on it. Okay, thank you.
Bethany had a good question that I think is a really good physician question because it kind of is a question about diagnostic parameters. She says, is it appropriate to diagnose an individual with OUD when they are only taking Kratom or 7-OH? What do we think, psychiatrists? Because I've heard, I feel like I generally hear people say Kratom use disorder, but it does have opioid activity.
I believe in the DSM-5 TR Kratom, it falls under
Other substance.
other substance use or hallucinogen. It was grouped with PCP when I checked,
That's an
which
odd
I found
bedfellow.
very odd. Yes. Yeah.
So
It's funny
here's
how
my
sometimes those
workaround.
are like,
So many of the individuals with kratom use disorder have a history of opiate use disorder or combined opiate use, and I latch onto that because my treatment is going to be in line with opiate use disorder treatment. So if they have any opiate use at all, even if kratom is their main issue, that is the direction I go, and I do diagnose them with opiate use disorder.
Ian, go
Yeah.
ahead. I see your hand is raised.
Yeah, that kind of makes sense to me, but in those rare cases where that is their sole substance, yeah, how do we do that? How do we go about that? I know our medical director she was really looking forward to me attending this because she has a lot of questions at one of the clinics she works at, where it's becoming more prominent. How do we deal with that? What is it classified as? I know DSM classifies it as a, like she said, the uh, um, in the realm of PCP, all that, but hallucinogenics. But um, has it been given a designation of is it a class 1 drug, class 2 drug, class 3 drug? What's going on with that?
does not have a federal schedule, I
Okay.
don't believe.
I believe whatever regulatory body submitted it in November to have specifically 7-OH, not kratom as a
Okay.
general, but
Okay.
7-OH classified as a Schedule 1. It has not passed. It has not gone through. It was just submitted, and it was just for the 7-OH, not for the whole compound, the whole plant, etc. So right now, that's how it's able to be sold in gas stations over the counter, is
Right.
because it is not a scheduled substance, and it
Right.
is not regulated in any way. But it could be on the horizon. But there are a lot of huge advocates. There's a Kratom Society that is very pro, and they have a lobbying body and all of those types of things. So there is a lot of advocacy for it as well, because it's also a big market too. So there's a lot of
Hey,
stakes there for a lot of individuals.
yeah,
We're seeing-
I'm a big proponent, for as someone said, HR. I guess we can't say that anymore.
You can, I can't. So
Okay.
that's fine. I will say that we're seeing plenty of state by state weird patchwork legislation attempt. I was literally on 35 yesterday and
Yeah.
got a call from a journalist in Florida who was like, so they took a break. The Florida Ledge took a break for lunch and came back and said, we want to talk about 7-OH. It was very it's odd. So we do have to pay attention. But no, there's no federal designation at this point. I I would it be accurate to say that kind of the best designation for it in the EMR would have to do with insurance, like what the patient has and what we can figure out for them?
Possibly. What about state funding?
Yeah,
Most of
all
our
good questions.
most of our clients are state funded, so
Yeah.
So I'm looking at the DSM now, and I actually don't see. I mean, maybe somebody else can find it with faster eyes. I actually don't see it under hallucinogen use disorder. Maybe I'm missing it. Uh,
No, I
and then
think I just remembered it was ketamine that's under
yeah.
hallucinogenic.
So it
Yeah,
actually,
so it's under other, I think.
Yes, I was
so
about to say that
I will
listed under
typically
other.
code it at other as an other substance use disorder, and then you can specify what the other is. If somebody has kratom use disorder, because even there is an other hallucinogen use disorder, but they do specify certain substances like salvia, Jimson weed, as other hallucinogens, and then like from a pharmacological or from an effect standpoint, we don't really think of kratom as a hallucinogen, so I don't know that it would necessarily fit under hallucinogen or other hallucinogen use disorder. So my preference is to use other.
and just make note of the withdrawal symptoms.
That's right. So you can call it an other and then parentheses say kratom use disorder.
Yeah.
I really
Thank you.
hate to interject on this really great conversation, everyone. But I do want to give time to our case presenter for today because he has some really great discussion as well, so we can continue it in the case. But we will jump to announcements really quick. Luckily, we just have 4 today, so we'll go through those and then we'll move to our case. But thank you all so much for your engagement. Karen, whenever you're ready. Thank you, Karen. So to claim your CME credits for today, please ensure you have a registered account first and then text attend 101-01-493 to the number you see on the screen no later than midnight tonight. And this information will also be shared in the post-session communication email. Next slide, please. CSTAT offers the option for free technical assistance for various substance use disorder needs and topics with our team of experts. To request technical assistance, please complete an online request form and we will be happy to assist. Next slide, please. And CSTAT also offers the opportunity to present a challenge or case that your organization is encountering to receive feedback from our hub of experts and our broader learning community. If you're interested in presenting a case, please contact us at cstat@uthscsa.edu. Next slide, please. And please join us at our next session on March 12th for a session on an update on novel and emerging drugs presented by our very own Dr. Crystal Walker. Thank you, Karen. And Dr. Dostal, once Karen pulls up the case presentation, please walk us through it. And while Karen pulls those up, as a note to Jasmine, our wonderful coordinator of this ECHO, looks like kratom is a topic. This could easily be a 2 or 3 part series kind of conversation. So it was really great to see so much engagement. Thank you, Karen. And Dr. Dostal, you can take it away.
Great, thank you. So this is my talk on, it's a case report on managing 7-hydroxy use disorder in a complex chronic pain patient that was encountered on our addiction consult service. And so next slide. So we have a 36-year-old transgender male with chronic pelvic and low back pain since around December of 2024, about 2 years duration. They have a history of schizoaffective disorders, stimulant and alcohol use disorders in sustained remission for also about 2 years. And they presented to the emergency department with 10 on 10 acute on chronic pelvic pain radiating to the abdomen and back, worsening over 2 weeks with vomiting and poor PO intake, as well as diarrhea. prior ED visits had shown within the week of being admitted, had shown a negative CT, negative CT of the abdomen and pelvis, negative transvaginal ultrasound, mild leukocytosis, minimal relief with morphine. The patient had a hysterectomy in October of 2025 with brief improvement of symptoms, and they had recently completed septanere for a presumed UTI, although cultures were negative. And however, they still reported persistent dysuria with pelvic pain. They endorsed passive suicidal ideation due to uncontrolled pain, no plan. They had a prior history of suicide attempts and being off psychiatric medications currently. So our addiction consult service was consulted on hospital day 9 because of a persistent high opioid requirement of approximately 135 millimorphine equivalents daily, including scheduled and PRN opioids, as well as a concern for a physiologic dependence in the setting of prior substance use disorders and refractory pain. So workup during the admission, and prior evaluations included an extensive evaluation, including another CTAP, MRIs of the cervical, thoracic, and lumbar spine, an EMG of the lower extremities, and their workup was only notable for a mild L4-S1 spondylosis without surgical indication. Neurology had interestingly documented positive roll-in signs for a functional neurological disorder, FND, including midline sensory splitting and non-anatomic sensory findings, supporting a diagnosis of a functional neurological disorder with central sensitization and a primary pain component. Psychiatry had already been consulted as well and had diagnosed a somatic symptom disorder. So medications at the time of the consult on hospital day 9 included oxycodone, extended relief, 40 milligrams, Q12, Norco 5, Q4, PRN, and the max estimated MMEs of 135. Non-opioid regimen included methocarbamol, 500 milligrams TID, meloxicam, 15 milligrams daily, and gabapentin, 800 milligrams TID. Next slide. So in June of 2025, the patient reported to me that they began using Kratom leaf due to this uncontrolled pain and inability to obtain prescription opioids because of their history of alcohol and stimulant use disorders. So he rapidly escalated to about 20 pills daily of Kratom leaf or capsules of Kratom leaf, and then transitioned to 7-hydroxy mitragynine. First taking 15 milligram tablets twice daily, then 30 milligrams twice daily, using the Pure 7's Max 60 product that's depicted there. It's available at gas stations and head shops for about $50 for a 5-pack or about $10 for a tablet. Initially, he reported about 4 to 5 hours of improved mobility and function, reduced pain. However, as his tolerance developed, he had worsening breakthrough pain between doses and physiologic withdrawal symptoms. So he met DSM-5 criteria for moderate other substance use disorder. However, Kratom 7-hydroxy, as we just learned, is an opioid. And so we diagnosed moderate opioid use disorder without with the specific specifically charting it as a 7-hydroxy use disorder. And so he had loss of control, tolerance, withdrawal, continued use despite harm, and the preclinical studies that have been reported in the literature do support 7-hydroxy's reinforcing properties and dependence, and they underscore that this is not a benign, as benign as kratom exposure. So next slide. This patient also has a significant psychiatric comorbidities, and we hinted that in the beginning. So they have a schizoaffective disorder with depression type, a history of PTSD from childhood sexual abuse, as well as prior suicide attempts. Their most recent was in 2019 by a cocaine overdose. And he reported passive suicidal ideation during the pain flares, which psychiatry during their consultation attributed to pain exacerbations rather than a primary mood relapse. So he has, as far as support, a strong social support, living with his mother and sister. He remains highly active and in our local recovery communities. He describes his sobriety as something that's external and his recovery as something that's internal or spiritual. And one of the main reasons he came and sought care was because he felt sedation from having taken a whole pill of the 7-hydroxy instead of his half pill, and he felt that that was threatening his recovery. So he works as a cashier, but experiences marked pain related functional impairment, as well as financial strain and transportation barriers. He walks to work. This complicates his sustained employment, though his family support helps him access specialty care. Next slide. So we had a risk-benefit discussion, and a lot of what was discussed in the prior talk, we also mentioned. For instance, the overdose risk, right, of 7-hydroxy, and what we've seen in the literature. Typically there's some combination of 7-hydroxy with alcohol or sedatives, and so after having a thorough risk-benefit discussion, the patient opted to buprenorphine induction. And so we used an IV microinduction protocol while he was hospitalized, with immediate discontinuation of the long-acting oxycodone and continued use of short-acting opioids with hydromorphone 2 milligrams PO Q4 PRN predominantly. And then buprenorphine was gradually introduced to reduce the risk of precipitated withdrawal. However, on induction day 3, he developed symptoms concerning for either precipitated withdrawal versus a severe pain flare. The patient was adamant that he was having a severe pain flare. However, he had also developed some other objective symptoms of precipitated withdrawal. He subsequently was stabilized on escalating doses of sublingual buprenorphine with titration up to 32 milligrams a day. And so his current regimen includes Suboxone 8 milligrams, Q8 hours with an additional 4 milligrams, BID PRN for breakthrough pain, baclofen, tizanidine for spasticity, and duloxetine for neuropathic pain, as well as he was started on Seroquel for mood stabilization. He was discharged from the hospital and referred to our SUD clinic, and FND, or functional neurologic disorder informed physical therapy, as well as pain psychology for structured pain neuroscience education. Next slide. So generally, high-dose buprenorphine is clinically justified for several reasons, right? First, doses of 16 to 32 milligrams provide greater mu receptor occupancy, reduce cravings, elicit opioid use, and have evidence showing longer retention and fewer emergency visits. Second, buprenorphine demonstrates no ceiling effect for analgesia in clinical practice, with small to moderate pain reduction in chronic pain populations, including those with central sensitization. So third, it has superior safety profile compared to full agonists with ceiling effect on respiratory depression, but not analgesia. And then finally, buprenorphine is a potential treatment or emerging treatment for 7-hydroxymitragynine dependency, but only supported by case reports and preclinical studies showing efficacy for detoxification and maintenance therapies. Next slide. Ethical considerations are central to this case. We must respect a patient's autonomy and lived experience. He reported improved function while using 7-hydroxy. At the same time, we must weigh this against substantial risks of unregulated high-potency opioid exposure, including respiratory depression, overdose, and death. The clinical question becomes, would we discharge a patient with this biocycle social profile on greater than 150 millimorphine equivalents of a full mu agonist, or with no opioid treatment at all? And neither extreme reflects a balanced, patient-centered approach. So, a risk reduction framework supported transitioning to regulated MOUD, which reduces overdose risks and other medical, legal, behavioral harms. And shared decision-making was required, including, ongoing dialogues and alignment with the patient's treatment goals for his function and recovery, while clearly educating him about the risks associated with 7-OHM. The patient ultimately did consent to initiating Suboxone with close follow-up and functional outcome monitoring to guide his continued therapy. Next slide. Our multimodal pain management strategy integrated non-pharmacological and pharmacological approaches, right? So we talked about the FND-informed physical therapy, and which uses motor training and distraction techniques and graded activity to restore normal movement patterns. Now, I spoke with some of our faculty physical therapists on the ward, and I couldn't find one that was trained in this type of FND-informed physical therapy. And interestingly enough, I only found one specialized FND clinic in Texas at UT Southwestern. So I'm hopeful that the patient will find physical therapy specialized as this, possibly up in Houston, either through like one of the neuro rehab centers or somewhere else in the medical center, because we didn't have that. And as well, as far as like the pain neuroscience education, this helps with reconceptualizing pain as a brain-generated alarm mechanism and reduces catastrophizing. So pain neuroscience, PNE, has been shown to be effective as an adjunct to FND-informed PT in FND patients. Now, as far as like the somatic symptom disorder overlay that's probably present in this patient, CBT-based pain psychology targets catastrophization, symptom focusing, emotional regulation, and trauma processing, with small to moderate effects on somatic symptoms. So pharmacologically, we're using buprenorphine for the 7-hydroxy associated OUD, partially off-label for analgesia, and duloxetine for neuropathic pain, and baclofen and tizanidine for the spasticity components. So we are avoiding full mu agonists due to OUD risk. Also, the thought that the patient may have opioid-induced hyperalgesia and the functional overlay. So our goal is to improve function, reduce pain, and enhance the quality of life. And part of like this is coaching the patient that it is going to be an incremental process. Next slide. The prognosis for severe chronic pain with FND and somatic symptom, and this trauma history is guarded, but recovery is possible with multimodal care. So converse, he has some good predictive factors, including, if he's able to engage with these physical therapists and specialists outside, as well as his active coping strategies and strong social support. However, some predictors of chronicity might include, high catastrophizing and his limit and inability to access specialized care. Next slide. So the final questions for the TRX community are regarding high dose buprenorphine. So in a patient with a moderate OUD related to 7-hydroxy, how do we justify escalations to 24 to 32 milligrams a day when a patient is reporting potentially superior function on a non-regulated opioid agonist? And ASAM and the American Association of Family Practice guidance support titrating buprenorphine to fully suppress withdrawal and cravings. But the idea here is that how do we best communicate the distinction to patients, right? And between what we're looking at with kratom and 7-hydroxy and traditional opioid use disorders. Second, in complex pain with FND and somatic symptom disorder, right? What are the optimal multimodal approaches to these patients, right? Are there practical algorithms to distinguish opioid withdrawal, mediated hyperalgesia, and functional pain flares during MOUD induction? I have no idea. And finally, how are sites overcoming access barriers to, pain neuroscience education or FND-informed physical therapy? And is there potential for telehealth pain psychology that anyone is aware of? And what scalable models, group visits, digital platforms, et cetera, have been successful in your systems? Thank you.
Thank you so much, Dr. Lostad, for this excellent case presentation and for all that you do and consider for your patients that you serve. Dr. Weems, Dr. Embers Weems, or Weems Embers, sorry. I pass the mic to you as our lead specialist for today to give us some thoughts and perhaps some closing remarks. And Jasmine, just to highlight, maybe this could be a follow-up case as well, so we can really dive into these questions. But go ahead, Dr. Weems.
Yeah, I just want to thank everybody for their participation today. Dostal, you got 100 people still in the room past 1 o'clock. So I think that's a high watermark. The kind of the first take-home point is that I hope is salient across our learners is that this is a patient who's presenting from several different identities that are disfavored within our healthcare system and often receive poor treatment. I think the depth with which you took this on and the teach, I learned so much from this presentation. Really reflects what can happen when people are dedicated to the best possible care, no matter what. So thank you for that. And I totally agree. This would be a rich case to just go back and continue discussing. The second take-home point I'll leave with folks is, that's right, you heard it, Dr. Dostal, an addiction medicine expert, diagnosed opioid use disorder in this patient. And we had a great discussion earlier about just how fast this the landscape is changing. Last year at the American Society of Addiction Medicine, where there was mostly addiction specialists in the room, there was a wide variety of different responses to that great question that Ian brought and that we're all still working through. And I love Dr. Walker's advice in the chat about using our best judgment to advocate for our patients and help them weigh risk and benefits. Thirdly, I want to give a quick plug. Texas is next week. If this is an interesting topic to you, there is a hands-on workshop Wednesday where we'll be talking more about Kratom 7-OH. And if you also had the experience of learning from Claire and thinking, I can learn anything from this person, she will also be teaching in that session. And Dostal can be found at La Tierra, I think Sunday night and Monday night, where he has a standing date with the mariachis there. So hope to see a lot of our audience today at Texas next week. Really looking forward to that.
That was an excellent end to today's session. Thank you so much, Dr. Embers. Thank you to everyone that attended. We hope to see you all at our next session on March 12th. And thank you for staying 4 minutes past the meeting time. Take care, everyone.